Good afternoon, everyone. My name is Paul Biedritsky. I serve as Director of Disease Control and Environmental Health with the City of Milwaukee Health Department. I'd like to welcome you back from hopefully what it was a good lunch and good networking session. This afternoon to start really regional perspectives from the Northeast. And I hear the Northeast is going to get pounded later today with climate, so if you can confine your remarks to that and climate health, that would be wonderful. Just kidding. But we have a very diverse panel this afternoon. To my right, I have Celia Quinn, who serves as the Director for, and I should have this down, I'm sorry, the Director for the Bureau of Healthcare System Readiness at the New York City Department of Health and Mental Hygiene. And Celia is also a CDC assignee to the New York City Health Department. Next to her, I have Matt Cahalane, a program manager with the Bureau of Public Health Protection, Division of Public Health at the New Hampshire Department of Health and Human Services to provide us with a state health department perspective. And then to his right is Kristen Baja, is a climate and resilience planner with the Office of Sustainability in Baltimore City, Maryland. So I think we have a good cross-section and representation of state and city officials representing the Northeast region. So without further ado, I'll turn it over to Celia.
Thank you, Paul, for the introduction, and also thank you to the organizers for inviting me to participate in today's roundtable. I have the dual challenge of being the first speaker after lunch and also the first one not to have a slide set to keep your attention. So I hope that I'll be able to make this story compelling enough to keep everyone awake for at least the next 15 minutes. And after that, I'll lean on the rest of the panel. I'm also, feeling a bit like an outsider, having not been working explicitly in the area of environmental health, and also not being an expert in climate change or climate science. But I've been serving in a leadership role in New York City's healthcare preparedness program for almost 3 years now, and it's really not an exaggeration to say that the bulk of our work to support New York City's healthcare system to respond safely and effectively in all emergencies are directly informed by our city's experience during Hurricane Sandy and the expectation that more frequent extreme weather events are in our future, including tonight and tomorrow. So my goal today is to share with you some of the Hurricane Sandy story through the lens of healthcare system resiliency, what the impacts of the storm were, how we responded in the immediate phase and in the ongoing recovery phase, how it changed how we think about healthcare system preparedness in New York City, and what healthcare system resiliency means now, almost 5 years after the storm. Some of the sources I've drawn from in preparing these remarks include the city's Special Initiative for Rebuilding and Resiliency report, part of the Mayor's Plan NYC initiative, health department documents including after action reports, and a recent very useful publication that I recommend it to anyone interested in this topic, which was published by the Center for Health Security, a community checklist for health sector resilience informed by Hurricane Sandy. I'll start by giving you some background on New York City's healthcare system and on what happened during Hurricane Sandy generally. I'll then give a more detailed view, zooming in on how the storm impacted the healthcare system and what we learned. And I'll close with some of our current efforts to strengthen healthcare system resilience and some thoughts about why a resiliency approach is so important in today's increasingly unpredictable climate. Throughout, my emphasis is going to be on planning and response coordination. This is not to de-emphasize the importance of hardening infrastructure or to imply that New York City isn't also working to make healthcare system infrastructure more resilient to a changing climate. It's just that that is not my own area of expertise, and it's not something that our health department is taking a lead role in New York City. So New York City's healthcare system serves the more than 8 million residents of our city, and like the city itself, it's diverse and complex. One way to categorize the parts of our healthcare system is to break them into 4 big categories. One is acute care and psychiatric hospitals. At the time of Hurricane Sandy, we had 70 hospitals. That included 3 VA hospitals. The second category is residential providers, so that includes our licensed nursing homes, 173 of them, and licensed adult care facilities, of which we have about 77, and more than 1,000 other residential programs that are for supportive housing to people with a varied different issues, including substance abuse disorders, developmental disabilities, or other behavioral and mental health problems. The third category is community-based providers, and these are any provider in the community that are offering ambulatory care services. They can be found in more than 10,000 buildings across our 5 boroughs. Among this group includes about 400 federally qualified health centers. That number has risen to close to 500 since 2012. We have over 100 dialysis centers. We have 67 methadone maintenance treatment programs, and countless other providers serving communities across the city. And the fourth category is home-based care providers. This is a category that's a little bit more difficult to describe, but is growing rapidly and is estimated to serve more than 100,000 households in the city at the time of Hurricane Sandy. So these providers and facilities make up an interconnected web of healthcare services, and as I'll discuss in a little more detail later, an impact to any one of these sectors can have a cascading effect on all of the other sectors. To give you a general sense of the number of healthcare facilities specifically that are at risk for coastal storm impacts, based on 2014 analysis, New York City has 67 healthcare facilities in the highest risk flood zones. Those are zones 1 through 3 out of 6 of them. In those 3 zones, there are 11 hospitals, 33 nursing homes, 23 adult care facilities, and a total of 15,289 licensed beds. So I said I would be giving you a high-level overview of Sandy, and I am going to get there, but I first need to talk a little bit about Hurricane Irene, which preceded Sandy by about 14 months. Irene, as it approached New York City, prompted an evacuation of healthcare facilities in advance of a storm that ended up causing less damage than had been originally predicted. At the time, though New York City was given an opportunity to test their evacuation systems, to some it seemed that the risk to patients and staff and the expense of the operation had been unnecessary when it turned out that the storm was not as severe as originally predicted. Ultimately, New York City did use the experience in Irene to make some improvements in planning for pre-storm evacuations in advance of Hurricane Sandy, but at the same time, the firsthand knowledge of those risks of a large-scale evacuation and the ultimate ease of repatriation to undamaged facilities after Irene had an outsized influence on decision-making at many levels as Hurricane Sandy approached the New York City area just over a year later. So this was a real-life example of the old emergency management adage warning against preparing only for the last disaster. This meant that the lessons learned across our system from responding to Hurricane Irene were inadequate when it came to time to respond to Hurricane Sandy. One reason is that Sandy was a very unusual storm. It was unusually massive with a wind field almost 3 times that of Katrina. It took an unusual course, the rare westward hook, moving out into the Atlantic before making a sharp left turn to hit New Jersey squarely on the coast. And it was also unfortunately timed, making landfall coincident with a very high spring tide due to a full moon at that time of the month. The storm surge in lower Manhattan ultimately reached 14 feet, 30% higher than the previous record set in 1960. In addition, the course of the storm pushed water up New York Harbor, leading to 2 different types of damage. First, wind and wave damage to coastal communities on the Atlantic coast, and second, still water flooding in the upper harbor, leading to later damage to mechanical, electrical, and telecommunication systems. So the next part of my story is about how this massive and unusual storm impacted New York City's large, diverse, and complex healthcare system. Many of you probably remember the healthcare evacuations that happened as a result of the storm. We all remember images of patients being carried by hand down dark stairwells, illuminated only by the light of cell phones, long lines of ambulances waiting to move patients out of nursing homes and hospitals suddenly without generator power, families searching for loved ones emergently evacuated from long-term care facilities to city-run special medical needs shelters. But the story of Sandy's impact on the healthcare system goes beyond healthcare evacuations and touches on every component of the healthcare system, so I'll try to bring in some of those stories as well. I do have to start with talking about healthcare evacuations because it's an important part of the story. In total, 37 healthcare facilities in New York City area were evacuated. This included 5 acute care hospitals, 1 psychiatric hospital, 17 nursing homes, and 14 adult care facilities. The health department's count of evacuated persons from healthcare facilities was 6,451, but that does not include patients who were rapidly discharged from hospitals or nursing homes in advance of the storm or transferred between or within networks also in advance of the storm. So it's likely that many more patients were impacted. By our best estimate, 1,800 vulnerable residents of long-term care facilities were evacuated to special medical needs shelters. In addition, several hospitals set up long-term care units in alternate space, like cafeterias or conference rooms, to accommodate an influx of evacuated long-term care residents emergently transferred by EMS. As planned, during Sandy, New York State Department of Health stood up the Healthcare Evacuation Center, or HEC, to coordinate the evacuation and repatriation of healthcare facilities. This is a state health department-led operation that's supported by key New York City stakeholders, including our local health department, New York City's Emergency Management Agency, Greater New York Hospital Association, and others. At the time, the HEC had been designed with Irene-like conditions in mind, which meant that the HEC leadership and staff had to continually modify their protocols and procedures to accommodate evacuations that were not conducted pre-storm, but were conducted during and post-storm, and to support facilities that experience very lengthy recovery periods, complicating repatriation. The PowerPoint version of this talk has an interesting photo that illustrates the cutting-edge technology that was used to accomplish this operation, which is basically telephones, whiteboards, and Post-it notes. In addition to the evacuations, the healthcare system did experience a lot of other impacts. 10 hospitals remained open and did not evacuate in spite of having power outages and flooding impacting their facilities. At least 65 long-term care facilities lost power at some point during and after the storm. More than 500 buildings that house community providers were in inundated areas. That's 5% of all of the buildings that have community providers in New York City. And another 1,200 were in areas that lost power. All provider types, but particularly home-based care, were significantly impacted by transportation disruption, travel bans, and lack of access to fuel. One result of the varied impacts of Sandy was an overall reduction in healthcare system capacity. In the immediate days after Sandy, hospital bed capacity citywide was reduced by 8%. The same 8% reduction in beds was also observed in the long-term care sector, but the impact lasted for weeks, with about 5% fewer long-term care beds 4 weeks after the storm. At the same time that there was a reduced capacity in the system, some parts of the system were experiencing a surge in demand for healthcare services. Some emergency departments were seeing storm-related increases in ER visits, and our health department's syndromic surveillance identified a surge in visits for basic medical needs, including methadone for patients in methadone maintenance treatment programs, oxygen, dialysis, and medication refills. Primary care and mental health services were also impacted, especially in certain hard-hit areas. A 2014 survey conducted by our health department indicated that among 40 primary care providers in the Rockaways, 95% closed or relocated at some point due to Sandy, and of those, 38% were closed for more than a month. So there are a number of key concepts. I won't talk about lessons because some of these were things that we knew ahead of Sandy, but were just really brought home by the experiences that we had during that storm. The first is that our healthcare services are interdependent. So even if hospitals have well-developed emergency plans for evacuation and shelter in place, long-term care and ambulatory facilities that are less resourced are more vulnerable to disasters. And importantly, the vulnerabilities in the non-acute care sectors have a direct and immediate impact on hospitals. Secondly, healthcare evacuation decision-making is complex. Again, this is not a new concept, but one illustrated by the evacuations that I described. Safe evacuation of a healthcare facility takes time, and the decision to go has to be made more than 72 hours before the storm arrives, a time period when the storm forecast is likely to be uncertain and the weather usually beautiful. The risk of evacuating fragile patients may outweigh the risks of sheltering in place, so the consequences of a decision to evacuate can truly be life or death. And of course, hindsight is 20/20, so leaders will be criticized for bad outcomes regardless of whether their decision in the moment was the right one. A third lesson driven home by Hurricane Sandy is the need for surge spaces of different types. Special medical needs shelters and even hospitals are not an appropriate location for residents of nursing homes and adult care facilities. But long-term care facilities are typically operating at 100% of capacity, and there are significant barriers to increasing surge capacity in the sector. Finally, planning for coastal storm and other natural disasters needs to take into account both immediate and long-term interruptions to healthcare services. In our experience, the ambulatory services in some hard-hit areas remained closed for a long period of time, and some long-term care facilities never reopened. So how do we translate these lessons learned into actions that result in a more resilient healthcare system? I'll briefly just describe a couple of our current efforts. First, in the city's report, the Special Initiative for Rebuilding and Resiliency that I mentioned, the report outlines strategies for a stronger and more resilient city. These include ensuring critical providers' operability through redundancy and prevention of physical damage, and reducing barriers to care during and after emergencies. The State Health Department has made enormous strides in improving the HEC operations, developing an online system for tracking evacuation and transportation requests. And in New York City's Health Department, we've leveraged hospital preparedness program and public health emergency preparedness funds to support a number of programs designed to improve healthcare system preparedness. Many of these, for the first time, beginning in 2013, focused directly on the long-term care sector. We've provided nearly all New York City long-term care facilities with radios for redundant communications, and we have a free technical assistance program for nursing homes and adult care facilities. Beginning in 2015, we began collaborating with the local hospital association, Greater New York Hospital Association, to co-lead an interdisciplinary work group to address some of the challenges of large-scale patient evacuation. We've focused on providing guidance for hospitals around standardized patient transfer forms and face sheets, getting agreement on definitions for bed types to facilitate matching of patients to receiving hospitals, and working on plans for advancing the planning for access of medical records between sending and receiving facilities. So in the interest of time, I'm going to have to leave it at those few examples. But to conclude, I want to share some thoughts about resiliency and why a changing climate requires approaching healthcare system preparedness with resiliency as a primary goal. Let me start by observing that when a disaster impacts the healthcare system is going to break in the places where it's already the weakest. So if a long-term care facility is already squeaking by on razor-thin margins just to stay open on a good day, they're going to have difficulty accommodating a surge of 20% of their licensed beds during a storm. Or for a community with few primary care sites and one or more of those are damaged in a hurricane, a community that already had difficulty accessing care now has no ability to access healthcare services. So what this observation has meant for me is that healthcare system preparedness has to go well beyond making plans or even training and exercising those plans. We need to move towards a resiliency framework where our goal is to make our day-to-day systems stronger, more equitable, more inclusive, more accessible, and offering more consistently high-quality healthcare services to everyone in our communities. And if we don't make that our goal, we can't be surprised when the healthcare system can't do what we need it to do when an emergency happens. Finally, I've focused my remarks today on coastal storms and the need to build resilient healthcare systems for more frequent extreme weather events that we know are likely to impact us in coming years. But climate change has other effects as well that we've heard about today, and that those will also benefit from strengthening healthcare systems and using a resiliency lens to ensure more equitable and high-quality healthcare. Emerging infectious diseases require us to strengthen day-to-day infection control practices, adhere consistently to recommended travel screening for patients with possible communicable diseases, and to improve communication between healthcare facilities and public health authorities. The potential for worsening heat waves make clear the need to consider adequate housing and access to city services as a public health problem, and to ensure that healthcare facilities can manage a brief heat-related patient surge as easily as they can manage a peak seasonal flu surge. So as these threats grow increasingly unpredictable, we need more resilient and adaptable systems, stronger relationships, and better collaboration before, during, and after emergencies to ensure the best possible outcomes for all of our community members. Thanks.